You have an excellent talk about trauma symposium. And you're going to talk on digital anatomy in surgical procedure.
Good afternoon, dear friends and colleagues. My last one. Okay, let me start from my talk. Today, I would try to make everything simple and easy for understanding. After I graduated my fellowship, in the first year I've seen I start to do the endoscopic DCR, the success rate is very low, only 81%, because I didn't know about the concept of the bone and the flap. After my talk, you're gonna see, I'm gonna want to share with you about my concept that I use in my practice. The first one is a bone concept. 20 years ago, when we learned about this one, we can learn from only 2 and 3 dimensions. We can learn from the skull bone anatomy in the anatomy department. We can use the light to see the thickness of the frontal posset of the maxillary bone. And if you have the CT scan, you can see before and after. This is only the 2 dimension and 3 dimension. Nowadays, I have found that when I use digital anatomy, that's helped me a lot for learning. We can use anatomy and learn about the frontal posset of the maxillary bone. We can bring the bone out and see the nasal mucosa, remove the mucosa, and see the maxillary bone, and see the relationship between the bone and the lacrimal sac, and see the relationship about the nasolacrimal canal, and see the ethmoid bone and the lacrimal bone, and bring the lacrimal bone and the lacrimal sac out and see the whole relationship in 360 degrees. And this is the ethmoid bone, and you can see the configuration of the Achilles cell and the uncinate posset, and including the inferior concha. And you can use this one and learn before the surgery and understanding and familiar really well. And at the same time, before the surgery at the night time, if you are the beginner, you can use the digital and drag application and learn to do the digital surgery at home. And when we started remove the flap and create osteotomy by removing lower 2/3 first. And you can see that in this step, we try to preserve the nasal mucosa as good as possible. And the second step, we remove the upper 1/3 of the bone. And in this technique, simply we use chisel and the mallet and remove inadequately and try to preserve the nasal mucosa as much as possible. And sometimes we have to remove the lacrimal bone also. And after that, from the digital anatomy, we can see the relationship. And sometimes we have to remove the Achilles cell and uncinate posset to expose to the whole area of the lacrimal sac mucosa. By the digital anatomy, if you do the external DCR, you're going to see the relationship and the difference. If we remove the bone from the orbital side, we can remove the bone very well, but we could not remove the bone underneath the medial canthal ligament. That's one of the limitations that I have found from the digital anatomy. Comparing to the endoscopic approach, we can remove the bone on the upper 1/3 adequately. So by the problem is the inadequate bony ostium and the poor flap approximation that can be the major factor that lead to the failure. So let's see about the mechanism of the failure case. And in this case, the previous surgeon removed only lower 2/3 of the bone, but not adequate, and damaged the nasal mucosa too much from the green area that you can see. For the healing, even we put the silicone stent, and when the healing process, the body try to initiate the scar tissue, and the scar tissue encroaching, and when you put the silicone stent. If you are lucky, when you put the stent and you take the stent out, you are lucky in that you're going to get the sum syndrome. But if the maturation of the opening of the sum syndrome is still active, when you a couple months, a couple weeks after removal, they initiate the total obstruction. Gonna fail from the. This is a good mechanism to show the scarlectite and scarlegmite phenomenon. In the failure from the external DCR, you can see in this diagram show a lot of scar tissue on the middle side of the lacrimal sac. That's gonna make the revision is so difficult. And after that, gonna be total blockage. From endoscopic approach for removal, you can see that we can remove the upper 1/3 of the bone adequately, and this is one of the most advantage comparing to endoscopic approach and the external approach. And you can see in this one, it show the green arrow show the bone that we can remove more than external approach. The next one is a flap concept. We use the digital intranasal flap management and the flap classification and suturing. If you are beginner, I do encourage you guys to perform the flap suturing. We can separate the bone by the digital application and see the relationship between the lacrimal sac and the nasal mucosa. Basically, we create the I-shaped flap. This is the most favorite one. Sometimes you can create the head-shaped flap. But the I-shaped flap is the more favorite one for mine. And you can see the whole space and the whole healthy lacrimal mucosa and see the common canaliculi. And this is from the endoscopic view. Many questions about what kind of the needle and the suturing. 20 years ago when I started, I used the S14, that's gonna be the 90 degree. But nowadays, I use 80 degree is called S22 needle. And because the needle, 180 degree needle, that have the curve enough to performing the flap suturing in intranasal cavity very good. For the classification of the flap suturing, I have the 4 classification. The most favorite one is anterior and posterior flap suturing. This is a video show and perform the flap suturing, create the anterior flap a little bit bigger than the posterior flap, and then rotate the anterior flap anteriorly, maximally, and I always perform 2 suturing. And this technique I allow my assistant hold the camera in the opposite side. So that allow me to use 2 hands for perform the suturing. This is a little bit difficult if you are the beginner, but trust me, try to keep practice. And when you be familiar, you can perform and create the primary intention healing, and the healing flap gonna be really well, and then the bleeding gonna be less, and the patient gonna feel more comfortably after the surgery. And sometimes if you have time, you can try to perform the posterior flap suturing also. That can initiate a very good new osteotomy. By the next one is the superior and inferior flap suturing. Sometimes we use the head flap and superior flap in the difficult condition like revision surgery. And this is the last one that I'm gonna show you is isolated flap suturing. This one gonna be cool and very practical for the difficult case and the revision case. This is gonna show the case that have to fail for many times from the external and endoscopic approach. The previous surgeon will make a lot of residual scar tissue. When you perform the revision, we can see the very thick scar tissue and no healthy inside the intralacrimal sac mucosa. So with the conventional technique, it will create the flap like this without the suturing. I'm pretty sure that the anterior flap gonna be rotated backward and gonna create the failure again. So this is the benefit. You can perform flap suturing, put the gel foam, inject the steroid, and sometimes MMC gonna help, and put the silicone stent. I would not say 100% for every endoscopic DCR, because even though you're gonna perform the very good bone and the flap concept, sometimes the generation tissue, inflammation, create the scar tissue. In this gentleman, he got the 6-month failure from the my surgery, and I did the revision in the clinic, not in the operation room. So this is can be performed in the treatment room easily by inject the numbing medication, create the vertical cut, and you can see a tiny mucosa. Just rotate a tiny mucosa or the scar tissue, imitate the scar tissue like a pseudo flap, and rotate anteriorly or superiorly, and then with one single suturing, you can create the permanent and complete the healing and get the very good new opening of the osteotomy. So by conclusion, the true target of the DCR is the internal common opening. The digital anatomy reveal what conventional anatomy high, and the flap suturing transform DCR from the drainage surgery to be the reconstructive surgery. Thank you very much.